Hello, everyone, and welcome to May's edition of St. John's Cancer Institute's Be Inspired Speakers Series, Cancer Treatment Options, the Development of Targeted Therapies. My name is Jean Goldsmith. I'm a Development Director at St. John's Health Center Foundation. St. John's Cancer Institute, formerly the John Wayne Cancer Institute, has been a part of St. John's Health Center for over 30 years. We have made a name for ourselves through our groundbreaking research, pioneering surgical techniques, and bedside translational medicine, focusing on major areas of cancer research, immunotherapy, molecular medicine, targeted therapies, and precision medicine that comes from analyzing each person's genetic markers that allow us to target treatment individually. We have a long, distinguished history in the advent of immunotherapy research. Our founder, Dr. Donald Morton, worked with BCG before its approval as the first immunotherapy to fight melanoma 40 plus years ago, and subsequently carried out a great deal of basic science, as well as researched some of the first immunotherapy vaccines for melanoma right here in our research facilities. St. John's Cancer Center is also home to the Donald L. Morton Complex General Surgical Oncology Fellowship Program, one of the oldest programs in the nation that trains the next generation of surgical oncologists. Our fellowship program has graduated close to 200 fellowship alumni that lead programs and are deans of departments in major cancer centers all over the country and internationally. We also have research fellows that come from around the world to train with our researchers and can be training with us from 1 to 4 years. Because of this academic level educational programming and world-class research, St. John's Health Center is in a unique position as a hybrid academic community-based hospital offering patient-centric care and academic level education and research. We also provide fantastic community education and are looking forward to today's webinar. Before we get started today, I have a few housekeeping items to share with you. So we would love to hear your questions today. And as you will notice, everyone but the presenters are muted so that we will all be able to hear them well. In order to ask questions, we will need you to use the chat function on your found on your screen. The chat function looks like a thought bubble, and it's found at the bottom of your screen, and we will see your question and we'll make sure to ask the physician. If we do not get to your question during the webinar, we will follow up with you, with everybody at one time with the answers. If you have a question after the webinar, please email us and we will get the answer to you. And you can communicate with us by replying to the emails that we have sent to you. Please note, we cannot answer specific treatment questions, but are happy to answer any question about the subject of the webinar. We will be recording today's webinar, and it will be available on the St. John's Cancer Institute website. And we will also send a copy of the recording to you via email if you would like to forward it to anybody. We have a very interesting hour in front of us today, as we'll hear from 3 medical oncologists and a neuro-oncologist who routinely use targeted therapies in the treatment of cancer. Each of these physicians treats different cancers, specializing in breast, melanoma, urologic, and brain cancers, and they all do research through clinical trials using immunotherapy and targeted therapies. I'm very honored to introduce the panel today. Our first panelist, Dr. Kim Margolin, is a medical oncologist specializing in melanoma and other skin cancers with a focus on immunotherapy. She came to Providence, St. John's from the City of Hope, where she worked for a total of 30 years, stopping out for a number of years at the University of Washington and at Stanford University. Dr. Margolin has co-led the prestigious Cytokine Working Group and the Cancer Immunotherapy Trials Network, participated in SWOG's Melanoma Committee, and served the American Society of Clinical Oncology and the Society for Immunotherapy of Cancer in many capacities. She served on the FDA's Oncology Drugs Advisory Committee and has been on 2 advisory committees to the European Organization for the Research and Treatment of Cancer. Among her research interests are brain metastasis and melanoma and immunotherapy of skin cancers. Dr. Margolin collaborates with surgical oncologists and researchers and leads the Institute's efforts in melanoma skin cancer clinical trials. Our second panelist is Dr. Parvin Peddi. Dr. Peddy is a medical oncologist specializing in breast cancer and is the director of breast medical oncology at the Margie Peterson Breast Center. Dr. Peddy is involved in designing and implementing and leading clinical trials to test new targeted therapies. She's board certified in internal medicine and medical oncology and came to us from UCLA Medical Center, where she was the lead medical oncologist at the Revlon UCLA Breast Clinic. Dr. Peddy was selected as a Howard Hughes Medical Institute scholar to perform research at the National Institute of Health. Her research has been published in various medical journals, including the New England Journal of Medicine. Our third presenter is Dr. Przemyslaw Twardowski. Dr. Twardowski, or Dr. T for short, is a medical oncologist and the director of clinical research in urology and urologic cancer at St. John's Cancer Institute and the Cancer Clinic. Dr. T came to St. John's from the City of Hope and is an expert in the management of genitourinary malignancies, including prostate, bladder, kidney, and testicular cancers. Over the last 20 years, he was a principal investigator and contributor to multiple clinical trials that expanded treatment options for patients with cancers of the genitourinary tract. And our fourth presenter and our moderator today is Dr. Santosh Kesari. Dr. Kesari is a board-certified neurologist and neuro-oncologist at St. John's Cancer Institute and at Pacific Neuroscience Institute. He is the chair of the Department of Translational Neuro-oncology and Neurotherapeutics at St. John's Cancer Institute and the regional medical director for the Regional Clinical Institutes for Providence, Southern California. Dr. Kesari has long been interested in cancer stem cells and their role in the formation of brain tumors and resistance to treatment. He uses targeted therapies and novel approaches to treat these often challenging cancers. Thank you for moderating today, Dr. Kesari, and please take it away.
Thank you, Jean, and thank you everyone for joining us today. It is a pleasure to moderate this amazing session on targeted therapy and with the amazing faculty members we have here at St. John's that are focused on different diseases. I did have a slide or two, just I'm not going to give you a 1-hour presentation, so don't worry. So cancer is very complex, and we've understood this better over the last 2 or 3 decades. And we hear a lot about immunotherapy as the previous sessions we've had here. And in the pink there is immune activating antibodies. So ipilimumab and nivolumab and many other immunotherapies we've heard about making amazing progress. But the rest of the things that make cancers grow and resistant to our standard radiation and chemo are also highlighted here. And many of these drugs that are developed for these different processes are targeted therapies. And in fact, even the immunotherapy or targeted are under the realm of targeted therapies because they're targeting the immune system to kill the cancer. So targeted therapy is really a broad topic, and really it involves making drugs that are specific to things that make a tumor grow, like as in this example here, EGFR or MET. You might have heard about mutations that cause lung cancer, for instance, and there are various signals in the tumor that we can make drugs for. And that's why they're called targeted therapies. They're not chemotherapies, which generally target the DNA, or radiation or other therapies that we use. So that's the definition of targeted therapies. And in fact, when I first started in neuro-oncology, there was only one drug, Gleevec, the first targeted drug ever developed for cancer, and that had an amazing impact on chronic myelogenous leukemia. And we've tried that approach for many other cancers, and we've seen some amazing progress with literally hundreds of drugs and approved in the last 20 years, and even more in development and approval every single year. And they're targeting what we call the tumor microenvironment, all the aspects that I showed earlier that cause a tumor to form, from the immune system not working properly to angiogenesis or new blood vessel formation, and then all these signals, the signaling molecules that make tumors grow. And so some of the examples that you hear about from the various speakers will talk about in the context of their diseases, what targeted therapies have been developed, from EGFR to BRAF to HER2. So that is really the context that we're having this discussion. And we may get into the interrelationship of targeted therapy and immunotherapy as well in some of the questions that you may ask and I may ask as well. So I will leave it at that in terms of the academic part of showing you the nice figures, but go on to asking questions. Dr. Margolin, you are a melanoma expert, and clearly both immunotherapy and targeted therapy have revolutionized that disease to something that was as deadly as brain cancer to now being a pretty well-managed disease for most of patients with amazing progress. Can you tell us about what are the targets that we think about in melanoma, and what's the progress there, and the drugs that you use?
Yeah, the rich scientific background for what's been discovered in terms of relatively melanoma-specific mutations that could be potential targets has really come around in the last several years. But unfortunately, there's right now only one very strong and medically important target in melanoma for which we have basically 3 regimens or pairs of therapy that do pretty much the same thing against that target. And that target is the BRAF mutation, which drives about half of the cutaneous tumors in Caucasian people, who, of course, are the main focus of melanoma. When people of darker pigmented races get melanoma, they usually get it on the hands, feet, and internal structures. But when white people get it, they often get it on the skin, and about half of the time, those melanomas have mutations in a protein, or the mutation is in the gene that gives rise to an abnormal protein, which is always on. It's always turned on. Most cells and most proteins in the cell have on and off switches that are very, very tightly regulated, but sometimes they get mutated and you can't turn them off. So when that happens, they may become uniquely sensitive to drugs that block that activity and all of the downstream or subsequent events that those proteins control. That's turned out to be an extremely important target in melanoma, associated with, if you give 2 drugs at a time, one for the mutated protein and one for the next downstream protein that isn't mutated, you can get remissions in well over 3/4 of patients. And those remissions last anywhere from 6 or 8 months to sometimes well over a year. But unfortunately, they rarely last for essentially a curative forever, the way we look at for immunotherapies. So we're still looking for targets that themselves don't mutate. What happens is the target itself can mutate and change, just like we all know now from the coronavirus. There are constant evolutionary pressures on proteins to mutate and be selected for the mutations, giving rise to stronger cells, and then the drugs are no longer effective. So it's a moving target, but it is an important target right now.
One of the questions that came up is about the side effects of immunotherapy, but maybe you can also comment on side effects of the targeted drugs you just mentioned.
Sure. The targeted drugs in large part cause side effects that are related to the fact that targeted is a relative term, and that there are always going to be either what's called off-target side effects or on-target off, what do they call it? On-target off something, where the target happens to be present a little bit in some cells that are not the tumor cells. Either way, you may get, as I said earlier, there are 3 pairs of drugs that work against the mutated BRAF target and the first downstream protein from there. And to summarize, the side effects consist of skin rashes, fatigue, sometimes joint pains, sometimes fevers, sometimes nausea. You can see abnormalities of liver tests that are performed on the blood when the patients come in to be checked. And then some of the drug combinations have unique toxicities, like one of them causes extreme sensitivity to solar, to the same kind of UV rays that we get from the sun that cause melanoma and other skin cancer in the first place, but they can make the skin extremely sensitive and you get an early sunburn. Others are particularly good at causing joint pains. Others cause these fevers that nobody's really figured out the cause of. So the one does have options if a patient has side effects with one of the pairs of treatment. You can try to fall back on some of the other pairs to avoid those side effects.
Great. Well, thank you. Dr. Peddy, what can you give us examples of targeted therapies in breast cancer and how you use them?
Sure. So breast cancers, in a way, we've been very lucky. And from the beginning, we've had ways of classifying different breast cancers in different baskets so that we can figure out targeted treatments for different types of breast cancer. So normal breast tissue, we knew relies on estrogen for growing. So the first targeted treatment for breast cancer was really to attack that. So about 70+% of breast cancers really rely on the estrogen pathway for their growing. So anti-estrogen treatments, such as Tamoxifen, were the first ones to come around that were able to not be like chemo that treats everything that is dividing, but rather target breast cancer cells that only rely on estrogen. So Tamoxifen, for people who are not familiar with it, basically binds to the estrogen receptor on breast cancer cells. So it's very targeted, and we forget that sometimes because it's such an old drug, but it was one of our earliest targeted treatments. So that's for estrogen positive breast cancer. And then in the late 1980s, we figured out another marker in breast cancers called HER2 receptor. And about a decade later, we figured out targeted treatments for that. So a drug that you guys have may have heard of, like from the audience who are not in breast cancer world, Herceptin and Perjeta and other medications like that that are targeted now against the HER2 molecule, that we can tease out who needs it and who doesn't. And the chemotherapy is really now reserved for some patients, the so-called triple negative breast cancers, that maybe the chemotherapy, which is not targeted, would be the main thing for them. But even for those patients, now we have some targeted treatments. So there's thankfully a lot of targeted treatments for breast cancer right now that we use all the time.
Wonderful, wonderful. Dr. Twardowski, what is happening in the field of GU oncology and targeted therapies?
Yes, so GU oncology, it's a heterogeneous group of diseases. They're kind of lumped together because of anatomical proximity, but the GU malignancies include prostate, bladder, kidney, testicular cancer. Totally different the way they are treated and the role of targeted therapy. No role for targeted agents in testicular cancer, very heavily relying on chemotherapy. Prostate cancer, on the other hand, has some similarities to breast cancer, what Dr. Peddy just mentioned, very much dependent on hormonal pathways. Obviously, different hormone in case of prostate cancer is testosterone, but we have had very effective agents that target that androgen or testosterone pathway that's been utilized for decades and with refinements over time. So we have multiple agents targeting that, but in the prostate cancer world, that's pretty much it. We really haven't identified very therapeutically relevant targets beyond that are highly utilized. In kidney cancer, again, totally different story, very much relying on immunotherapy and also targeted therapy as well. So a specific target that is critical for biology and growth of kidney tumors is called VEGF. That's the molecule that kind of stimulates blood vessel formation by kidney tumors that are very heavily supplied with blood vessels. And there are multiple drugs. I counted 9 targeted drugs that we have approved in kidney cancer that specifically block that VEGF protein or VEGF signaling. And then the bladder cancer, the fourth of the group of tumors that I tend to see, is also quite interesting in terms of recent developments of targeted therapies, although they fall maybe into slightly different categories, something that we call antibody drug conjugates. So those are kind of the hybrids of drugs that have a certain properties of chemotherapeutic agents, but they are being delivered in a very targeted fashion, exploiting some presence of specific proteins on the surface of bladder cancer. So I would probably classify them, in my mind, they would fall into that group, and they're very, very effective. And we have 2 drugs approved in that category.
Well, great. I will just make a few comments about brain cancer. We have not been as successful as the rest of the colleagues here, but there's a lot of successful on a scale that gets drugs approved, except in a very few cases. In fact, it turns out those drugs that help are actually the same drugs that the team here uses, whether it's for breast cancer, lung cancer, or melanoma. We have rare cases of BRAF mutation in gliomas, primary brain tumors. We've had cases of PI3 kinase, which is one of the pathways mutations in gliomas, and we've used, for instance, everolimus, a breast cancer drug, and also HER2 drugs that Dr. Peddi mentioned. So we do have success, but it's a very personalized success that we're seeing, except in cases of everolimus, where it's actually approved for a very rare type of brain tumor associated with a familial disorder, hereditary disorder called tuberous sclerosis, where they develop these brain tumors that are slower growing, but nonetheless symptomatic. So I think maybe what I would like to ask is, obviously, you know, cancer is a team sport, and I'd like the speakers to talk about brain metastasis and how that impacts targeted therapies, because, you know, we tend to share these patients that develop cancer in the brain, sometimes many years out from their original diagnosis. Maybe Dr. Peddi, since that's probably the largest bucket of cancers that tend to, the largest volume, but they also tend to go to the brain as well. And what are the risk factors for that? And how do you manage differently with targeted therapies in those situations?
Thank you. Great question, because as we're getting better and better in our drugs, in the rest of the body, the brain is proving, unfortunately, a sanctuary sometimes for some cancers that go to the brain and we cannot reach it. We cannot reach it with a lot of our drugs. So what basically our bodies have a thing called blood-brain barrier for the audience that basically is a good thing usually, meaning it keeps chemicals and things we eat that may not be so great from going to our central nervous system. But when it comes to getting cancer drugs to the same place, then it becomes a handicap for a lot of our drugs that are too big, too large to try to get through this blood-brain barrier. So it has proven to be difficult in some cancers more than others. So a lot of our anti-estrogen treatments, for example, do not go to the brain. But some of the anti-HER2 drugs perhaps are going to be able to be going to the brain, but it has to be one of the smaller molecules. It cannot be one of our larger ones. But there are some that we've had some success with, such as, for example, a drug called Kadcyla, or another drug called Enhertu, which are targeted drugs that are small enough that could potentially go to the brain. And they're still somewhat targeted. And then there are chemo drugs that go to the brain as well. And we try as much as possible not to go to the last resort of injecting medications basically into the spine. It's called intrathecal chemotherapy. That would then for sure go to the brain. But that's an area of active research, trying to figure out targeted drugs, whether they're targeted medications, whether targeted chemotherapy, that can basically go through the blood-brain barrier. And right now it seems like the molecule just has to be small for the most part to be able to get through and get there. And there are some in anti-HER2 realm that can do that. And there's some just regular chemos that would hit everything, but not much more than that, which is why myself and Dr. Kesari work a lot together, unfortunately, because a lot of these patients come up that don't have a whole lot of things that are on the market right now, and where research is really needed to try to figure out what's the next best thing that we can come up with.
Yeah, I have to say though, compared to 5-10 years ago, amazing progress is in controlling the disease. And actually, Dr. Margolin deals with a lot of brain metastases as well. And maybe you can comment about melanoma and how you see the changes in targeted therapy whenever there's brain involvement.
Yeah, thanks. You know, just since we're going to veer over as a result of your question to a little bit towards immunotherapy, which happens to work better than targeted therapy in patients with melanoma and brain metastases. I just want to point out what we didn't say at the very beginning, despite the very elegant slides from Dr. Kesari, which is that, you know, basically all forms of therapy for cancer are targeted to a certain extent. They're all designed to, you know, the reason why we use different drugs in colon cancer and breast cancer and lung cancer and liver cancer and so on and so forth, but some of them are the same, is that there are, again, there are certain proteins, whether they're mutated or not, that are the same in some of those cancers, and they're enough different from the normal tissue of those organs that we can take advantage of that differential. And the same thing is true for their toxicities, where, you know, maybe the hair falls out, maybe the bone marrow is depressed and we see low blood counts, but those things come back even in the setting where the cancer doesn't. So that's kind of the ideal. So target is a relative term. Probably immunotherapy is the least targeted form of treatment because everyone has white blood cells, and most of these drugs work against, you know, the kind of white blood cells that everybody has to a certain extent. In terms of the brain, it's turned out that work over the last 7 or 8 years has shown that despite the fact that we think of that blood-brain barrier that Dr. Peddi talked about as a fairly tight netting that protects the brain against certain substances that shouldn't be there, and so forth, there are sort of leaky areas of that membrane or that barrier at sites of cancer, and we can take advantage of that to see that some of the drugs that would ordinarily not get into the brain actually can. Furthermore, white blood cells, especially the lymphocytes, the ones that kill cancer and that are necessary, they're actually very flexible, and they can sort of bend in half, and they can become sensitized against cancer out in the bloodstream, but then they can squeeze across that blood-brain barrier and get into the tumor site. So you know, I don't think we have elegant videos of that the way we do in animals in certain instances, but we have data that at least indirectly shows that. And we have even better, we have clinical data that show that in melanoma, the same drugs that work against melanoma when it's metastatic to body organs, such as the liver and the lungs and the lymph nodes, can give you responses of metastases or tumors that have spread in the brain, as long as they're pretty small, as long as they don't require steroid therapy. We rely heavily on steroid therapy to reduce the swelling and the inflammation that occur around many tumors that are growing in the brain. In fact, most tumors to a certain extent will cause that inflammation and swelling. But in the presence of steroids, unfortunately, either those brain metastases are really bad actors, which is part of the problem, and the other problem is that steroids themselves are immunosuppressive, and all of the work that you're doing to try to stimulate the immune system against cancer can be really blocked by the presence of steroids. So I'll stop there and let other people talk.
Thank you. Shemek, any comments in the GU world?
Yeah, so I think, you know, there's a lot of similarities, perhaps how we manage brain metastasis. I think, you know, brain, of course, is such a critical organ that, you know, anytime we see development of brain metastasis. It's a kind of a semi-emergency in many cases. So bigger tumors, symptomatic, very critical role for surgery to remove the dominant tumor, reduce that swelling that Kim was talking about, and perhaps follow up with radiation. In the smaller, in the setting of smaller asymptomatic metastasis, perhaps detected incidentally on imaging, we have obviously more time, and some of these drugs that I use in my practice can be helpful, particularly the targeted drugs in the kidney cancer. I've seen patients respond sometimes quite well, and there's good literature for that. So that will be an option in kidney cancer, which is linked to relatively high incidence of brain metastasis. The other cancers that I see, prostate, fortunately extremely rare to penetrate CNS, the same bladder cancer, for some reason, typically doesn't go there. So that's a good news on my part that I don't have to typically worry about it. The testicular cancer can certainly go to the brain, and then we have to use surgery and radiation typically to handle that.
Thank you all. And I think what is clear here at St. John's is we have a very multidisciplinary approach to managing cancer, especially metastatic cancers. When they go to the brain, all the different members of the team, whether it's melanoma, GU, breast, lung, we get together and discuss each patient's case and figure out the optimal treatments. As you heard, surgery, radiation, including targeted radiation. We have amazing new technologies where we can do this very focused radiosurgical approaches, they're called, pinpoint radiation to the tumor so that we avoid whole brain as much as possible in many of these tumor types. And it turns out it's actually also more effective in controlling the disease as well. And then when you combine it with targeted therapy or immunotherapy in certain situations, you can really get the most benefit about a multidisciplinary approach, as well as reduce the side effects from those various approaches. So I think multidisciplinary teams is one of the critical developments that we've had at the St. John's from the beginning, but more so in the last few years, focused around various tumor types. And I think that's a tremendous value add for patients in our program. So on that note, maybe for each of the speakers to maybe talk about a trial or two that you're doing related to targeted therapy in your disease areas, and what's exciting in the clinical trial arena in your fields. Maybe Dr. Peddy to start with.
Sure. So one of the earliest things like that came up like just in the last I shouldn't say earliest, the latest things that came out in the last 5 or so years are the so-called Cdk46 inhibitors. So that are very targeted for breast cancer patients who are estrogen positive, and it's basically they inhibit a protein or two that are involved in the cell division of cancer cells. And when you combine that with anti-estrogen therapy for patients whose cancer, they have stage 4 breast cancer, but it's estrogen positive, if you give them anti-estrogen therapy plus these drugs, which is just a pill, they live twice as long. Their cancer takes twice as long for the cancer to become resistant to anti-estrogen therapy. So that has been around now for the last, like I said, 5-6 years or so. And so the drugs are Ibrance, Verzenio, and Kisqali. But the question still remains, what do you do after that? So for the patients who get as the first treatment, this combination, once their cancer becomes resistant to this, what do you do? So the current standard right now to go to a different anti-estrogen drug, but no companion pill anymore. So you basically go from a two drug combo to a 1 drug combo, but because that's the best you have, you don't have a combination one that can enhance the basically the efficacy of this medication. So one of the trials that we have open now, has been open just for the last month or so, is a very new drug, is a pill also, that inhibits a different pathway called AKT pathway. And it was one of the pathways that Dr. Kesari put up on that beautiful slide that had the many different things that basically can get affected in a cancer in general. And that pathway, this is basically is another growth pathway, another signaling pathway, has intersections with the anti-estrogen, basically the estrogen pathway. And if you inhibit both of them at the same time, you may be able to really enhance how much response you get. So this trial is basically for patients who have stage 4 breast cancer, have been through these Cdk46 inhibitors. So they've gotten the top of the line for the first line, but now it has done all it can, and you can have to go to the second line of an anti-estrogen therapy. And this drug basically then is a companion to this that these patients wouldn't be getting otherwise. Otherwise, standard of care would have been just plain anti-estrogen therapy. So that's a drug that is targeted, that I'm very excited about, that is now open just in the last month, that is open to our stage 4 breast cancer patients. We have many other ones that are in the pipeline. We have another one that is not so much targeted, but is immunotherapy for triple negative breast cancer patients that don't qualify for the traditional immunotherapy that is on the market right now, because that doesn't work for all of our breast cancer patients that are even triple negative. They don't have this so-called PDL1 marker that predicts response. So for patients that can't get that, we have a trial with a new type of immunotherapy that could potentially work in them. That is, it's not available otherwise. And is only available through a clinical trial. So I'll stop there, but those are some of our newer clinical trials that we're very excited about that are targeted / immunotherapy drugs.
Great, thank you. Dr. Margolin?
Is there a specific question?
Sorry, I was asking, is there any 1 or 2 trials that are exciting in this targeted in your area that you'd like to talk about?
Sorry, I didn't realize we were still on the same question. I'd actually like to tell folks about a trial that we haven't activated because I just didn't think we were going to have enough patients. But in fact it is struggling a bit to get accrual. But I think it's a good example of this. Of what we melanoma folks have to think about all the time, which is whether, how, and when to potentially combine targeted agents with immunodrugs. So in fact, the leader or the overall PI, principal investigator for this trial, who's currently a faculty member at Moffitt Cancer Center in Tampa, Florida, was one of the fellows at the City of Hope where I used to work. And she's very talented. She wrote a trial and pushed it through, and I say that seriously because it takes a lot of work and a lot of energy and fortitude to get a study activated in the US cooperative groups, but those are a very, very important place to test certain things. And so these are all drugs that are already on the market, and in fact, some of them are not necessarily approved to give together, but they're like drugs that are approved to give together. And it's a randomized trial. So for patients who have melanoma with metastases to the brain, who have not previously received targeted therapy or immunotherapy, and so you're treating their disease outside of their brain as well as inside of their brain. The patients are randomly assigned to either get, and of course goes without saying, their tumor has that BRAF mutation that I mentioned earlier, because these drugs cannot and should not be used for people whose tumors are so-called wild type that don't have this particular mutation. The treatment is a randomized assignment to either receive one of those 3 pairs that I mentioned earlier. It happens to be the drugs encorafenib and binimetinib, otherwise known as Braftovi and Mektovi. And that would be the standard targeted therapy, and plus nivolumab or Opdivo, which is the one of the 2 most commonly used PD-1 or immunotherapy drugs, one of the milder ones. And the other patients, the other half of the patients, are randomly assigned to receive what you might consider standard immunotherapy for patients with brain metastases, at least, as I said before, for those who do not rely on steroid to control the swelling around their tumors. And so the idea is to identify which of those regimens is superior, either combining targeted therapy with one immunotherapy or using the more aggressive immunotherapy and holding off on the targeted therapy until and unless the patients do not respond to the immunotherapy. I think it's a wonderful study, and I think most of the people in the SWOG melanoma committee are very fond of the study as well. But because it's really hard to identify people who have a mutation, who have brain metastases, who don't need to go either to the surgeon right away or to the radiation doctor right away, who don't need steroid, who are willing to go in a trial, who haven't been treated with treatment before, you know, the bar is very high, the filters are very, very tight, and it becomes extremely difficult to get patients on the trial, as important as it is. So just something to be aware of. I gave it more as an example and a little bit of the science rather than saying that it's necessarily going to come to fruition, because I think it's kind of a cool trial.
Great. Dr. Twardowski.
Yeah, so I would maybe point out two clinical trials that we have at St. John's that I think are most exciting from my perspective. One in prostate cancer. So I've mentioned before that we haven't been maybe super successful in identifying targets for prostate cancer outside of the testosterone hormone pathway. But one of the emerging very important targets that has therapeutic application is called PSMA, prostate-specific membrane antigen. So it's kind of an equivalent of PSA. PSA, many of you maybe in the audience are familiar with PSA, which is protein that it's secreted into the bloodstream by prostate cancer cells. PSMA stays on the surface of the membrane of the prostate cancer, so it presents itself on the surface as a target. It's really present in almost 100% of cases, and we have a clinical trial utilizing kind of a hybrid molecule. It's a protein that has a specific affinity for that PSMA molecule on the surface of prostate cancer cell. And it's combined with the radioactive agent, radioactive isotope called lutetium-177. So the idea here is that the PSMA molecule serves as a target to which the radioactive isotope is delivered and locally radiates cancer from within. So it's kind of a hybrid concept, but I think it does fall into the targeted therapy realm in general terms. It's a targeted radiation, if you will, but from within. It's an injected medicine. So we are using it in combination with hormone therapy in patients who present with metastatic prostate cancer, hoping that will improve outcomes in the long run. The other example of interesting, I think, clinical trial that we have in our portfolio is in kidney cancer. And kidney cancer, we have a very, I think, well-established what we call frontline regimens that rely heavily on immunotherapy in combination with kind of first or second generation targeted agents. These agents really have moved the needle significantly in kidney cancer in terms of improvement of survival. But unfortunately, still very few patients get cured from in the setting of metastatic kidney cancer. And we have a clinical trial in the second line setting. So this would be for patients who might have responded well to frontline therapy, but subsequently had disease recurrence. And we're using agent that addresses or targets kind of new, relatively, well, it's not newly discovered, but I would say was brought to the front of kidney cancer biology within the last few years. A molecule called HIF2 alpha, HIF2 alpha. There was actually a Nobel Prize awarded for work on that whole pathway related to it a couple of years ago to Dr. Kalin from Harvard. So we are testing the drug that specifically targets that molecule for patients who no longer respond to frontline therapy. I think it's a very novel an important study, an example of kind of new developments in targeted agents.
Thank you all. I'll just give a few examples from the brain tumor world of targeted therapies and trials. It turns out that brain tumors are very diverse, meaning no one mutation predominates these tumors, and it's 10-20% of this mutation or that mutation. So it's a very, what we call a heterogeneous disease. And that's why when we do these trials of drugs, we don't see a high percentage of response. And that's why it takes a long time to do the trials, and it really, and the drugs don't get into the brain, et cetera, that we discussed before. But having said that, we do have many trials that are targeted therapies for these small populations. One of them is FGFR mutation tumors. It's for any cancer type, but obviously my team is focused on the brain tumors, and we had this trial open by Insight that is now, we had one patient from Hawaii come right before COVID, and he's still on the study after having a recurrence of his glioblastoma a year and a half now, almost 2 years out actually, with just one drug with complete response in the brain, and he still comes every month with manageable toxicities. And we have now a whole slew of studies opening at St. John's as well as across all of Southern California at all of our other ministries. As Jean mentioned, I'm responsible for research across all of these 11 hospitals in Providence. And so we're trying to open these studies so that patients have access as close as possible to where they live. And so we have NTRK, which is another target, and NTREK, as well as Hedgehog and other FGFR and EGFR and other mutation studies in the future. In fact, the field of targeted therapy is moving to the point of similar to what we call match trials, where you sequence the patient's tumors. We are doing so much sequencing these days on everyone's tumor. We're identifying that in some brain tumors, we see melanoma mutations, as I mentioned, BRAF, but also breast cancer mutations. So we're using drugs that were developed originally for other cancers and repurposing them, whether it's a trial or off-label use for brain tumors when we don't have other good options. And I think you will start to hear more about that over the next 5-10 years of really moving into a new era of personalized medicine, where we're really going to individually sequence every gene in the tumor and use that information to develop the best, to use the best drugs for each particular tumor type. So I think this was a great discussion, and I just want to summarize before a few questions from the audience that I see here, is that this really truly is a multidisciplinary approach. What Dr. Morton started 30 years ago in the field of immunotherapy and now expanding the targeted therapy is really critical for improving outcomes in our cancer patients, especially the tumor types you heard about, but actually all solid tumors. And in fact, Dr. Margolin, Dr. Twardowski, and others, and myself, we are opening a host of studies which are regardless of the tumor type. If you have that mutation, we have a drug for you. We're also starting up trials in the oncolytic virus space. It's a different form of immunotherapy and targeted therapy where we're using viruses to kill the tumor and then stimulate the immune system to also do its job. So you'll see a lot of that coming up in the near future. We have a few of these options available right now for a variety of solid tumors. And I think it's a very exciting, probably more exciting now than ever before, of a combination of immunotherapy, personalized therapy, and targeted therapy for all kinds of cancer patients. And I think it's it clearly having an impact in our clinic. And I think the audience will see more and more of that over the years. So I wanted to thank everyone for doing that, talking about your field. But there was one question that I'll answer to, which was, would targeted therapy help with meningiomas? Now, this is a slow-growing tumor. We do see it's on the surface of the brain, not in the brain. And as we age, there are more and more patients that develop meningiomas. And there's no approved treatment. So we usually do surgery and radiation whenever the tumors continue to grow and we can't control them. And over the years, actually, we've used hormonal treatments. Some of the drugs that Dr. Peddy mentioned that target estrogen, progesterone, and growth hormone receptors. And they've been variably helpful in patients. And what we're doing now is to do a combination of targeted therapies based on the hormones present on the tumors, as well as we sequence these tumors, again, we're finding mutations in NF1, EGFR, etc., such that we can use these other drugs along in these meningiomas. So I think that field is also changing over time, and our team is focused, and we will probably develop a meningioma specific program in the very near future based on what we're seeing with a variety of drugs in our clinic. So what I'd like to, I know we only have 5 minutes left, but if there are other questions, please put them into the chat right away. So there was a question about how we work with outside researchers. And in fact, each one of us has connections to researchers at UCLA or Cedars or City of Hope, and even further away, and then even internationally. And so we do work with researchers. Many of the company-sponsored studies are actually multi-center, so they could be local or distant researchers. On the translational side, which we didn't get a chance to talk about, we also do tissue-based and other types of research that are our own ideas. And we certainly work with a variety of investigators at other institutions to do that. And as well, you know, I forgot to highlight the fact that as part of the development of targeted therapies is really monitoring disease. And we are now in the era of liquid biopsy, where we're looking at DNA in the blood and actually using targeted drugs based on the mutations that we find. We can find a HER2 or a BRAF mutation in the blood or the spinal fluid, and that's enough for us to order that drug for that patient. And that was also developed actually at St. John's Cancer Institute. Dr. Dave Hoon and Dr. Morton over the years have done some amazing studies looking at microRNAs and circulating tumor DNA in the blood of patients with cancer. And that technology, some of that has been licensed out to other entities over the years. So the Institute should take credit and does take credit for developing some of these new diagnostic approaches, which has actually helped with the targeted therapy revolution that we're in right now.
Dr. Kesari,
yeah.
Are we doing liquid biopsies for all tumor types, or are we just doing it for a few tumor types? Because I know we're doing it a lot for lung cancer.
So there are individual programs, research projects for lung cancer. We do it in our brain tumor population, but it is also commercially available. So physicians have the option to order that test and to understand. Some of it may be helpful for finding a mutation, especially when you can't rebiopsy. But in other situations, it's potentially useful for monitoring disease. There's been examples in breast cancer and other cancer types where it could potentially help you decide whether a drug is working earlier than imaging can. So I think we'll see more and more of that incorporated into the field. And that actually raises a good question that you're probably hinting at, cancer detection. And Providence has rolled out a program where we're detecting cancer early, even before our clinical test, whether it's a mammogram or a skin exam or a CT scan in smokers, et cetera. Now we can do a liquid biopsy in high-risk patients and other patients where we can identify circulating DNA in the blood that could potentially suggest a risk of developing a cancer. And that's a study with GRAIL and others that we started in the last year and is very active in screening patients that could potentially harbor a cancer that would be not detected by our routine methods or not indicated to do a chest CT or a mammogram, et cetera.
Yeah, and I would add to that as well. Gene, yes, it's done for almost all cancers, including breast cancer. It can be done and routinely done. I just did on a patient today in clinic who is not easy to do another biopsy on. and but you know this person has circulating tumor cells. So you do that instead to be able to find out more about the cancer just through the blood circulating cells.
And just to complement that, we're also participating in, although we didn't invent, a sort of a targeted immunotherapy imaging, which is using a novel PET scanning tracer to look at a marker on the immune cells that are required to go into tumor that represent the mechanism whereby our immunotherapy drugs work. And if we can show, that those cells are going into tumors during treatment, it may be a substitute for biopsying or for some of the blood markers or for, changing therapies or not changing therapies, depending on what that tells us. So it's across the board of, ways to find cancer and find how to treat it.
Right.
Yeah.
Well, I just want to say,
I just want to say something before you end. That I just appreciate the world's expertise in the different tumor types that we have on this panel and many others that are not on the panel at the St. John's Cancer Institute. It's really, as a neuro-oncologist, that I know you guys don't want to send your patients to me to develop brain mets, but sometimes we have to. But it's really, as a neuro-oncologist, in treating patients with brain metastasis, it's an amazing collaboration. And I just want to thank our colleagues because I learned so much about what's happening in all the other fields that helps me apply for our brain cancer patients. I also just want to say, I was in clinic, but I stepped out into this new infusion center, which is opening in a few months. And that's why I'm not wearing a mask. I'm in clinic, but this new infusion center is really going to change the game for St. John's Cancer Institute, because this is where we collaborate, where multidisciplinary, all of our patients come. We can, any patient that has a headache, a neurological problem, whatever, we can see as a team patients in our new infusion center, which is right in our clinic area. So I'm super excited and fortuitous that I found this quiet place in the infusion center that's opening soon to be able to talk to you guys without a lot of people running around behind me. So thank you, Jean, for helping set this up, and I'll let you close the session.
fantastic. And when you first came on, I saw the infusion center and I was so excited to see it. So I'm glad that you're using it. And so thank you, everybody. Another fantastic session. Really incredibly interesting information about targeted therapies. And it's really important to be able to communicate this to everybody out there, our community. So we really appreciate your time. So, what used to be three therapies for fighting cancer, surgery, chemotherapy, and radiation has really grown to include immunotherapies and targeted therapies. Things are changing very quickly, because we have this research institute right next to the health center, this translational medicine that we do, patients have the opportunity to, have the advantage of having that research that's being done here, and that helps their treatment. So it's an incredible time in cancer research and cancer care and treatment. And, for all of us that are on right now, these panelists are really doing state-of-the-art research and care. We're so lucky to have them. So thank you again for being here today. So, on these webinars, we highlight the work of our cancer team, that our cancer teams do for our patients and our cancer research worldwide. We can't do this this research without your support. So thank you for considering how you may help support this critical work going forward. You can go to our website and you can donate there. You can respond to the emails that we have sent, and I would be very happy to have a conversation with you about how you could support our work in cancer research and treatment. And as mentioned on the last webinar, we're excited to announce that starting this summer, we're moving our webinars to podcasts so that it would be available for you to watch at any time at your convenience. You don't have to come at noon to 1. You can watch it any time that you would like. We're going to be filming, 2 podcasts a month, and they will be found on the St. John's Health Center website. And as you've been wonderful supporters of our webinar series, we'll be sending you sneak peek links to our podcast a week prior to it going out to the general public. So please keep your eye out for an email from us about podcasts featuring our physicians and researchers, not only in cancer, but in the neurosciences, cardiac care, orthopedics, women's and men's health, and digestive health. If you have any questions, please send us an email, and we're happy to answer any questions or get information to you. And from all of us at St. John's Health Center and from the St. John's Health Center Foundation, thank you so much for joining us today, and we'll see you again at some point soon.